Hi everyone, this is NU214, and this lecture we're going to talk about cancer, the care of the cancer patient, and some of the oncological emergencies. I will be breaking this into 3 parts, so this would be video number 1. All right, so first things first, let's talk about some of the statistics of cancer. Basically, this is a disease of aging. Sometimes in the past, we didn't have a lot of information about cancer. Probably up until like the late 1800s, early 1900s, we started to see more and more people with cancer. And honestly, that's because people were living longer. Before then, people would die before some of these mutations which cause cancer could actually occur. So cancer is known as a disease of the aging. So most cancer diagnoses do come for those who are over 55. The largest cause of death for cancer-related deaths in the United States is actually lung cancer, and tobacco use is figured prominently in that. We've had a lot of changes to treatment, and science has kind of pushed us forward so that a lot of times in the past, cancer would be a terminal diagnosis. There weren't really a lot of treatments for it. But now, more likely than not, you're going to be taking care of patients who are living with cancer as sort of a chronic disease, right? So they may have hypertension and also cancer. Back and forth, there'll be a lot of people that really it's more of a chronic disease because we are getting better and better at treating cancers. Some cancers, of course, depending on what variety and some of the other factors, are certainly not really treatable, but certainly more than they used to be. And then those who may not have cancer currently, they may have had a history of cancer. So I want you guys to always keep that in the back of your mind, that somebody who had cancer treatment in the past, they have some issues with survivorship that weren't close monitoring and follow-up as well. So we're going to talk a little bit more about what actually is cancer, and then we'll go into some of the nursing things. All right, so the first thing we have to understand when we talk about cancer is the actual normal cell cycle. So this should be a review from some of your anatomy and physiology that you've had before. But basically, our cells divide. It should be an orderly process. They go through different phases. Sometimes the cell is resting and it's not actually doing anything at all. It's not dividing. And then sometimes it's dividing. So what happens with cancer has everything to do with the cellular life cycle and metabolic activity. So cancer, the biology there is 2 major problems occur. One is that the cell proliferation, so growth, that cell growth becomes defective, as well as differentiation. So we'll talk about these a little bit more as we go into these. But so those are the 2 main principles behind cancer: uncontrolled growth and defective proliferation. So let's talk about proliferation first. So, and I guess we have to kind of talk about proliferation and differentiation a little bit together, but our body has stem cells in it, and part of our biological understanding is that all of our cells specialize after becoming, they start as stem cells and they get chemical messengers and other activity that tells them to go be, I don't know, like a lung cell, an ovary cell. You're going to be a hair follicle, right? So once that occurs, once the cell differentiates, it then starts to reproduce as its own type of cell, right? They only become one tissue type. And our cells are controlled by on and off switches that tell the cell it's time to divide and then tell the cell stop dividing. So for example, if I were to fall and break my leg, my body would recognize that I would then need some more bone cells, and I would get the on switch to make more bone cells. And then once that's completed, then the off switch would tell my cells to stop. So saying on and off switch is very simplistic, but it gets the point across that these are they're messengers, they're hormonal messengers and chemical messengers, but they work as on and off switch. So the problem with cancer cells is that they no longer are responding to the on and off switches. In fact, some of the on and off switches become cancerous and they're always stuck on, sort of like pressing the gas in the car and not being able to take your foot off the gas. So that would be the on switch stuck on. Or the other would be that the tumors, like the off switch, would not be able to be turned off either. So sort of like cutting the line to your brakes. So when this occurs, the cells start dividing incessantly. Now, understand that our cells do divide, but again, we're responding, our normal cells are responding to those on and off switches. So cancer cells really are dividing at the same rate as the normal cells of the tissue for which they're coming from. But because of them being cancerous, they divide indiscriminately and kind of haphazardly. So sometimes they're creating more than 2 cells, even at mitosis. So this is why they end up clumping and some other things that happen. But in general, they're not actually dividing faster than the normal cells that they are. It's because it's so haphazard and that they just don't stop, right? The other cells would be responding to those signals to stop dividing. And then let's talk about differentiation now. So this kind of goes into this slide. And again, anytime you want to pause and rewind, you can. You can speed my voice up, slow it down, whatever you want to do. But these are the on and off switches. So remember differentiation. Cells become capable of performing specific functions. So 2 of the genes that can be affected would be proto-oncogenes, right? Those are the on switches, and the tumor suppressor genes, those are the stop switches. So proto-oncogenes, if they pick up a mutation, they become oncogenes, and those are the abnormal on switches. Tumor suppressor genes, however, they basically slow the cell. So everybody has these. We have proto-oncogenes. We all have tumor suppressor genes. It's just what happens after that. So remember what I said, that when our cells go through differentiation, they become capable of only performing specific functions. When we have defective differentiation, what happens are that the cells that were specialized start to revert to the fetal stem cells from which they came, right? So this is the basis for tumor markers. All right, tumor markers. That's a very important concept that I want you to remember. Tumor markers like the CEA, AFP. So basically, when we have these cells that are returning to their fetal form and functioning, some of them start to throw off fetal proteins, and we can measure those, right? So a little quick review is that there's problems with proliferation. We lose the normal dynamic equilibrium, which causes a net increase in the number of cells. There's a loss of what we call contact inhibition, meaning that the cells no longer stay where they're supposed to be. They're growing on top of each other. Instead, they should be orderly and laying down, but they're not. And the proto-oncogenes promote growth. Mutations change those proto-oncogenes to oncogenes. And then oncogenes return the cell to a fetal form and functioning. And that's the basis of our tumor markers. Meanwhile, tumor suppressor genes inhibit growth, and loss of the tumor suppressor gene is like cutting the brakes on the car. So some of our tumor suppressor genes that you may be familiar with would be like BRCA1 and BRCA2, which are implicated in ovarian and breast cancer. APC, that's what mutations there causes familiar adenomatous polyposis. And then there's something called a P53 tumor suppressor gene. That is a very common one. Mutations are found in many, many cancers, bladder, breast, etc. So remember, once these cells differentiate from stem cells, they don't generally return to their earlier states outside of cancer. So let's talk about the development of cancer. So we know why it is. Let's talk about how it is. All right, so the first things that happen is something called initiation. That's the first stage. It's when we have a mutation of the cell's genetic structure. The second stage is promotion, and that's when we have exposure to other, I guess you would say, compounding factors, causes reversible proliferation. So remember, reversible. That means that if we stop some of the influence of the other activities on the cells, we can actually avoid cancer. So what are some of those promoters? Alcohol, smoking. Smoking is both an initiator, like the tobacco is an initiator and a promoter. Obesity, so losing weight. And then finally, progression. When we have progression, that is the last stage. It's characterized by increased growth in the rate of the tumor, as well as invasiveness, spread of the cancer to a distant site. So when we do talk about cancer, one thing I want to mention is that there's a difference between inherited versus acquired cancer. Genetic predisposition, though, is really only up to about 5 to 10% of all cancers. So most cancers are not inherited. The majority of cancers are caused by exposure to carcinogens or cancer-causing agents. So what are some of those carcinogens? Let's take a peek at them. All right, so tobacco smoke, single most lethal carcinogen. It's also a promoter. And this includes chewing tobacco. Alcohol is a promoter. Certain viruses can be carcinogens, as things like Burkitt's lymphoma, so Epstein-Barr virus, Kaposi sarcoma, which is seen in AIDS. Hepatocellular cancer can be caused by hepatitis B. Not hepatitis, but HPV can cause cervical, head and neck cancer. Some of the other things would be occupational exposures. These are a big deal. Farmers working with pesticides, people who work with chemicals, anybody who's had previous treatment for cancer. So let's talk about radiation for a minute. So radiation can cause cancer basically in any body tissue. Can cause leukemia, lymphoma, bone cancer. UV exposure can cause skin cancer. So that's always important teaching. Just a reminder about our viral carcinogens. So here's the list of them for you. We've already spoke about them. All right, carcinogen is the hormonal agents. So breast, prostate, uterine cancer, those all tend to depend on hormone levels. So exposure to hormones can be a carcinogen, which is why when we talk about family histories, we want to know what age did the female first experience her period, because the longer the exposure, the more chance there is for cancer development. And I have these a little out of order. I'll make sure they're right in your slides, but I just wanted to remind you about promotion is reversible and progression. But again, we've already talked about that. My slides were just out of order. So when we have all of these things happening in our body, all these viruses, hormones, radiation, all these promoters and carcinogens, why is it that we don't get cancer? Why doesn't everybody that's just walking around just have cancer? And the answer to that is what we call immunologic surveillance, right? The immune system. So our immune system has active surveillance of self versus non-self. All right, so we have our natural killer cells, which actively lyse cancer cells, and we have our B cells, which make antibodies to bind to cancer cells, right? See, some cancers, they actually have cell surface antigens, and you can see that right here. I'll put my little marker there so you can see it. And tumor-associated antigens are also found. So our body can recognize those and can actually target those cells. So if we can get rid of the cells before they have a chance to divide or exert their influence, then our body evades cancer. So that being said, there's a lot of reasons why we don't actually evade the cancer, right, too. So next slide here. Why is that? Well, let's be realistic. Our cancer cells aren't coming from another species, right? They're coming from our own human tissue. So sometimes they're not going to be seen as non-self. The other things, sometimes the tumors themselves, the cancer cells, secrete substances that protect them and also throw the immune system off the scent, right? So they secrete immune suppression proteins. And here's a slide that I want to bring your attention to as well, like our cancer cells. We talked about this slightly before, but here it is for you to actually look at. I think it's important that you do know some of these tumor markers. Some of them are easier to remember than others, like CEA. A lot of times we see that with our GI cancers. Alpha fetoprotein for liver cancer, CA125 for ovarian cancer, CA19-9, that's pancreatic, prostate-specific antigen, so you'll see that in prostate cancer. So these are your tumor markers, right? I don't think that you need to memorize every single tumor marker that's out there, but I do feel like these are some that you should know. And if you're not sure, you can always just pick out what you think they are. If they say something's like a tumor suppressor or if something is a tumor marker, take the clues from those cells. Now, cancer can be described as either benign or malignant. And the big difference is, as you see it here, basically the ability of the malignant tumor to invade and metastasize. Benign tumors can't necessarily, they can't metastasize, but because of their growth, they can actually they can still cause death, not to the same degree. So some have described them as slower growing. Truthfully, they have the same cell division, but they really, the biggest definer is the inability to metastasize for a benign. So malignant can and often do metastasize. They move to other parts of the body. All right. So if you ever had a question on NCLEX or something like that, it really is basically that benign cannot metastasize, and that's because benign has a capsule. It's encapsulated, and you don't see that with the malignant cancers. All right, so how do we classify cancer? So we basically do it on the anatomic site, so meaning like the tissue of origin, so carcinoma, anatomic site, tissue of origin, whether it's benign or malignant. Then we do histology. So histologic classification, that's basically done by the person with the microscope, right? That tells us for histology, how close do the cells look like the tissue it came from? And that can go in 4 different grades, 1, 2, 3, 4, and X meaning it can't be assessed. And then we have what we call staging, and that's going to tell us the extent of the disease, so based on metastasis. So there's a couple different staging that we do. So the first one we'll look at is just like the, well, that's our grading. So remember, grading is grading's done by the microscope, but staging is done by clinical. So staging is 0 through 4. 0 is called cancer in situ. So basically, when you have something that's in situ, it means that it has all of the other classifications of cancer except invasion. So it's going to be staying right there at the tissue that it originated in. And then stage 1, that just localized. 2 is limited local spread. 3 extensive, and 4 is METS. And the TNM staging, we are very much interested in the TNM staging because that's probably the most common that you're going to see. Like somebody might say, I have stage 4 cancer, but when we look as practitioners, we look at the TNM staging. So why do we like this is because basically it gives us a way to talk to other clinicians, and we can basically all speak the same language. It's something that's quantifiable. So T is the tumor size. So 0 is no evidence. TIS, which isn't listed up here, but that's in situ. And then 1 through 4. N stands for the lymph node spread. N0 is what we'd like, which is that there is none, but it could also be 1, 2, or 3. And then distant metastasis, which is whether or not there is any METs to any other area. We are now adding hormone receptor expression, so you'll see that with our breast cancers. It might be like stage 3B, HER positive or HER negative cancer. And then we can also add restaging. So we never really decrease staging, but when we do restage somebody, you'll know it because it'll have an R in front of the TNM. So far we've talked about what is cancer, what's the difference between benign and malignant, how do we grade and stage, and guys, you're responsible for knowing the difference between grading and staging, and you're responsible for knowing TNM and basically everything we've talked about. So now let's talk about some of like the signs of cancer and how it's diagnosed, right? So right here is something called caution. It's the warning signs of cancer. You can pause and take a read on this, but basically it's a mnemonic that will help you remember what the warning signs of cancer are. So if we know that there's changes in bowel and bladder habits with some cancer, this guides our nursing care, right? Asking a person about their bowel or bladder habits. Ask them about their skin. Is there any area on their body that they're worried about? Any bleeding, any discharge? We ask about their ability to eat, changes in warts or moles, anything that's nagging and not getting better. And then actual diagnosis of cancer. We diagnose cancer using any number of methods. Among them, you can see listed here. But what I really want to put home to you guys is the definitive way to diagnose cancer is through the biopsy. So when you have this slide and you're looking over it, you can actually click on that video and that will show you a biopsy. So we can do biopsies many different ways. We could just do a needle, we can take a core, we can get an incisional procedure or excisional, right? Are we getting a piece of it or taking the whole thing? And this is a great place to talk about something we'll talk about in breast cancer, but the sentinel lymph node mapping. So basically, when we know where an area drains, that lymph node is called a sentinel, from like soldier, right? It's the guard. So one of the things we can do now is go and sample that sentinel lymph node, because if it's negative, then we know that the cancer did not go further than where it came from. It saves a lot of time and trouble with some of the treatments, and allows us to have more minimally invasive techniques, and instead of like going further and further, because one of the things we know is the more lymph nodes we take out, the more likely we're going to have lymph node dysfunction and lymphedema. So here are some of them. So excisional versus incisional. The biggest difference is excisional. Think about excising something, right? You're taking it out, and that allows you to actually get the tumor and the surrounding tissues, because honestly, guys, those margins are so important. We want to know that we have clean margins around whatever we're taking out. And then incisional is if the tumor is too large, or maybe in an area you can't get the whole thing excised, then you could take a piece of it. Fine needle aspiration is when you take the cells rather than the tissue, and that's often done under radiology. They might need like an ultrasound guided. Then the core needle biopsy, it's when they go right into the core and grab some out. Getting a diagnosis of cancer can be life-altering for a patient. So we expect that they would go through the stages of grief. This doesn't always go with just dying, right? So any sort of bad news, changes in their health, can have the person experience grief. And we may see these. This is nothing new. The stages of grief. Remember, it's not always one after the other. It's not always cyclical. You can go back and forth. You can go from one stage back to the other, anger, and back to denial. But the one true fact is that you start with denial and you should end with acceptance. So the person who is diagnosed with cancer is, like I say, more than likely going to be anxious, fearful, stressed, depending on their age, where they are in their life, the type of cancer. We always want to know what type of cancer it is and what the prognosis is. And being a nurse can help you along those lines. Like somebody who has a very slow-growing, non-invasive prostate cancer, though it's still a cancer diagnosis, may react completely differently than somebody who's 45 years old and has a diagnosis of stage 4 pancreatic cancer, right? So we have to know what sort of cancer they have, the prognosis, because we can start to help them a little bit better. So I think we can spend some more time. Actually, I think we'll pause here, and I think we're going to we'll stop here, and we'll pick up the next lecture with cancer treatment. So, all right. So again, this was part 1. I'm not sure if we'll have 3 or 4 parts. I'll let you know. Thank you.